We know that about 3% of patients with non-small cell lung cancer have mutations in a gene called MET, and it's specifically a region called MET exon 14. And what we've learned in the past year or two is that patients who have this mutation can respond to treatment with MET inhibitors, drugs such as crizotinib or other drugs that are available through clinical trials. And there are ongoing studies trying to examine what percent of patients who go onto these types of drugs who have these MET exon 14 mutations will respond to therapy. But one of the things that we wanted to do was to see, compared to patients who, in hindsight, were found to have these MET exon 14 mutations who never received treatment with targeted therapy with a MET inhibitor, what was their survival compared to patients who have been receiving targeted therapy with MET inhibitors. And we actually found a very striking difference in our retrospective analysis. We reached out to many other institutions that all participated and collaborated together to contribute data. In total, we had 61 patients with metastatic non-small cell lung cancer with these MET exon 14 mutations. About 34 of those patients had never received a treatment with a MET inhibitor, and 27 patients of that set had received treatment with a MET inhibitor. Most of these patients received crizotinib, not through a clinical trial. This drug, crizotinib, is approved in the US and is actually available in close to 100 countries for the treatment of other kinds of lung cancers that have ALK and ROS1 rearrangements. But oftentimes we're able to prescribe it to patients in an off-label setting for the treatment of MET exon 14-mutant non-small cell lung cancer. And the survival, the overall survival for patients that never received treatment with a MET inhibitor was 8.1 months. And by contrast, the survival for patients that did receive treatment with a MET inhibitor was almost 3 times as long. It was about 24 months. So, there are some limitations to doing a retrospective survival analysis. There are certain biases or imbalances that can occur when you do this type of study, but ideally what we'd like to do would be to do a randomized prospective clinical trial, randomizing one group of patients to receive a MET inhibitor and one group to not receive a MET inhibitor and see how they do. But for our targeted therapy trials in the past for lung cancer, it's been difficult to demonstrate a survival benefit through those types of randomized prospective trials, because sometimes the trials build in crossovers so that if you're assigned to not get a MET inhibitor and then you progress on standard chemotherapy, then you would cross over to receive a MET inhibitor, or after you come off the trial, there's a lot of post-progression use or treatment with MET inhibitors. So a lot of our other studies, for example, in EGFR or ALK mutant lung cancer, those randomized types of studies typically demonstrate differences in response rate or progression-free survival, but typically there's not a significant difference in overall survival. So that's why we felt one good approach to addressing this big question about survival, because that's really what we care about the most for our patients, along with tolerability, is to do this retrospective analysis.